Now we'll be talking about the ACE inhibitor, that is angiotensin converting enzyme inhibitor. Now, these ACE inhibitors can be used in any hypertension except when they are contraindicated. So, where they are contraindicated, if the patient has bilateral renal artery stenosis, so occurrence of or incidence of this bilateral renal artery stenosis is very very uncommon. So almost this drug can be used in so many hypertensive patients where it is not contraindicated. Uh, as alone, this drug is effective in almost 50% of the patients, and whenever it is used with other drugs, especially diuretics, the efficacy increases to almost 90%. So they are one of the very good anti-hypertensive drugs. They improve the renal blood flow, they retard the diabetic nephropathy. Actually, they reduce the proteinuria, albuminuria. That is how it prevents the CKD progression. So there are very few drugs for hypertension which can actually reduce the proteinuria, which can actually prevent the chronic kidney disease progression. So this is one of the most important drug which is used for nephropathy. Whenever the patient, whether he is diabetic or non-diabetic, if they have proteinuria, if they have albuminuria, it means that the patient is at high risk for developing chronic kidney disease. And to prevent the progression of this chronic kidney disease, these ACE inhibitors, they are one of the excellent drugs to start with. So even if the patient doesn't have hypertension, even if the patient only has diabetes, and if the blood pressure is stable like 120, 130, 135, in presence of proteinuria, we can still start angiotensin converting enzyme inhibitor, even if the patient doesn't have hypertension. So the other beautiful properties of these AC inhibitors is they have capacity to regress the left ventricular hypertrophy as well as vascular hypertrophy. So automatically it modulates the morbidity, the mortality associated with heart failure. They reduce hospitalization associated with this heart failure. They automatically improve the quality of life that is associated with LVH, hypertension, hypertensive heart disease, and heart failure. So these ACE inhibitors, which includes the captopril, enalapril, ramipril, this must be always considered whenever the patient has diabetic, so as to prevent the diabetic nephropathy or CKD progression. So any diabetic patient, whenever they are diagnosed, we must always do urine albumin creatinine ratio. We should always do urine routine and microscopy to see whether this patient has proteinuria or not, whether this protein is 1 plus or 2 plus or 3 plus. Whenever there is 1 plus, 2 plus or 3 plus, means patient has proteinuria and patient is at high risk of worsening to CKD. So diabetic or non-diabetic nephropathy, we should always consider ACE inhibitors. Whenever there is LVH, that is left ventricular hypertrophy, which can be evaluated by doing 2D echo, where we can see whether the patient has mild LVH, where the ventricular diameter will be around up to 1.2 centimeter, 1.2 centimeter to 1.4 centimeter interventricular diameter, we call it as moderate LVH, and when it is more than 1.4 centimeter diameter or width of the ventricular wall, we call it as severe LVH. Severe LVH means patient will have significant diastolic touch dysfunction and patient will have shortness of breath, chest pain, angina, all these symptoms will be there. So congestive heart failure is one of the most important indication for ACE inhibitors, because in this congestive heart failure, the morbidity, the mortality, the recurrent hospitalization, the risk of sudden cardiac death, and the risk of all-cause mortality will be markedly improved by this ACE inhibitors, that is angiotensin converting enzyme inhibitor. So post MI patients, again there will be significant activation of renin, angiotensin, aldosterone system. That will be same again in congestive heart failure. So this has to be used. And those patients who are angina, they can have much better outlook or much better quality of life if these patients are put on the ACE inhibitors. They have shown to have a huge 14% reduction uh, in cardiovascular mortality. They have cardioprotective benefit, and one of the most important problem with this ACE inhibitors is they have dry persistent cough as a side effect. So those patients who have dry cough should not be uh, put on this drug. And if the dry cough is persistent, then that may be the indication to stop the drug, and then a patient can be switched to angiotensin receptor blocker, that is telmisartan, olmesartan, these drugs. One of the most commonly used drugs are Ramipril. It is extensively used. Captopril, which is extensively used. Enalapril, which is extensively used. The dosage for Ramipril, which is very commonly used, varies from 1.25 milligram to 5 milligram. Most of the patients will be on 5 milligram or 10 milligram, and it can be used up to 20 milligram. Same with Enalapril, which can be used started from 2.5 milligram, and it can be given up to 40 milligram, but most of the time it is used up to 5 milligram or 10 milligram. And for captopril, it can be used up to 100 milligram per day. Whenever the glomerular filtration rate is less than 40 ml per minute, Ramipril should not be given, and it should not be given to more than 5 milligram per day, because less than 40 means the patient will have a higher chance of having hyperkalemia and hyperkalemia associated complications. So the benefit of these ACE inhibitors, they have significantly shown to reduce the cardiovascular mortality. They are shown to reduce the hospitalization for heart failure. And even if the patient has or not have any symptom of LV dysfunction, whenever there is reduced ejection fraction, then whenever there is LV dysfunction, this ACE inhibitor must be considered. It should be, or it must be, the first choice in those patients who had MI, myocardial infarction. If the patient doesn't tolerate this ACE inhibitors in post-MI patient, then ARB can be definitely considered to reduce or to give the cardiovascular benefit. Usually, ACE inhibitors and ARBs combination should be preferably avoided, but it can definitely be used together also, especially if the particular drug is given in the morning, second can be given in the afternoon or in the evening, especially for the blood pressure control. If there is, whenever we start this Ramipril or Enalapril, after a period of 7 days to 14 days, we should definitely repeat the serum creatinine level. If there is less than 25% of the serum creatinine rise after starting this ACE inhibitors, then we can definitely continue, and we can keep on monitoring the serum creatinine every 14 days to a month. If there is more than 25% rise in serum creatinine, then we should definitely discontinue, because the patient may land up in acute kidney injury, or patient may have hyperkalemia. The drug can be again started at a lower dose, and again serum creatinine can be rechecked after 7 days or 14 days. That is the reason why before starting this ACE inhibitor, we should always measure serum creatinine and serum potassium. This drug is definitely contraindicated in pregnancy, so should not be used. And this drug should not be used if the patient has angioedema, because this angioedema is very uncommon. It is seen in very, very less patients, especially less than 1% patients. But if the patient has developed angioedema because of this drug, then definitely that drug should not be used again. So this was all about ACE inhibitors, that is Ramipril, Enalapril, Captopril, and all the prills which are out there, especially for hypertension, and to reduce the mortality, morbidity, hospitalization, and to prevent CKD progression in diabetic or non-diabetic patients. Thank you.